All right, can we get started again? Everybody can have a seat and we'll get going with our next speaker. Our next speaker is Susy Hota. She's an assistant professor in the Department of Medicine, Division of Infectious Disease at the University of Toronto. Dr. Hota completed her medical training at the University of Toronto, where she also completed her residency in internal medicine, specializing in infectious disease. She went on to complete a Master of Science in Clinical Epidemiology and joined the University Health Network Infection Prevention and Control Department in 2007. She has acted as a consultant on several Ontario hospital-wide outbreaks of nosocomial infections and has participated in a number of infection prevention and control program reviews. She has a special interest in management of Clostridium difficile and is the principal investigator in the first North American randomized controlled trial evaluation fecal transplantation for the treatment of recurrent CDI. Yeah. All right, and today she's going to be talking about reprocessing errors and what have we learned from them. Please put your hands together and welcome Susy.
Thank you very much for that kind introduction. So I'm coming to you today as an infectious diseases physician, but also one who does spend a majority of her time in the infection prevention and control department of her organization. So some of this, what I'll be talking about, is going to be based on what's published, what's out there in the literature, what we can learn globally, but also some of it is coming from my experience as well. I should also note that I've taken part in a number of reviews that came out of our College of Physicians and Surgeons of Ontario as well, related to out-of-hospital premises and whether or not reprocessing errors required any kind of further follow-up. So this is something that is near and dear to my heart, much like it is to you. Oh, I have just pressed a button. Okay. So I just wanted to start by saying that I have no disclosures that pertain to this talk to reveal to you. Okay, I can press the button. So we're muting the sound on that. So I'll start off today by talking generally about reprocessing errors, what kinds of reprocessing errors, a little bit of the background. Then I'll go on to some of the published experience and what we've learned from them, and hopefully give you some take-home messages on each of those. Then I'll go on to talk a little bit about risk assessment, because that's such a critical piece here. And finally, I'm going to end off with more of the experience-based stuff, so some of the common challenges that we face with reprocessing errors and things that lead to that kind of risk. So this is something that's probably very familiar to you. It comes from the IPAC document on cleaning, disinfection, sterilization of medical devices. And as you know, there are a number of things that are important components for reprocessing effectively, starting from when you're thinking about purchasing a piece of equipment. And I should add that it's beyond purchasing equipment. Now with lots of research going into innovation and design of how we do things in medicine, increasingly clinicians are modifying pieces of equipment that are existing and trying to make them more efficient or get some more utility out of it. And sometimes that's not done using the proper channels in terms of how do you reprocess this. So that's something we always have to be aware of now. We focus a lot of our time and energy looking at the centralized reprocessing procedures and what's happening there. And in fact, yes, that is an important component, obviously, of where breaches can occur. But there are other things that also can feed into this. And at any point in time in this cycle, you can have an error that results in a reprocessing problem. Now, again, we're probably all familiar with the Spalding classification as well, and what we are supposed to be doing depending on the type of risk of whatever your device is, how it's going to be exposing the body to what parts of the body and tissue it's going to be exposed to, rather. And most of it is pretty clear-cut to us. I think we understand the difference between critical, semi-critical, and non-critical devices. However, there are some things that don't quite fit into this nicely, and an example of that would be cystoscopes. There's still debate on how we're supposed to be dealing with certain types of instruments, so that's another thing that complicates the issue of reprocessing. When we talk about errors themselves, quite often we refer to them as an endoscopy error, reprocessing error, a cystoscopy device reprocessing error. So it can be referred to as a problem on the level of whatever procedure or types of instruments that are involved. But you also obviously can refer to it as a primarily cleaning problem, high-level disinfection or sterilization, depending on what the need is of the instrument. And I put here, just as kind of a way to frame what I'm going to be talking about, a quick note on the reuse of single-use devices and reprocessing of them. I'm not going to talk much about this, and it isn't really a reprocessing error per se, but I think there's some common themes in terms of the risks associated with that, and I wanted to just quickly bring some of that up later. So part one, I'm going to go on to what's out there in the medical literature. And I was jokingly saying earlier that the title of this talk is What Have We Learned from Reprocessing Errors? And how I could almost summarize in one statement, absolutely nothing, because really there's not a lot out there. And there's still a lot of debate and controversy about how to deal with things. But I've highlighted a few cases that I'll go through that I think are of interest and have some points that are a bit unique that's out there in the medical literature. And it's not by any coincidence that I'm starting with an endoscopy case, because this is probably the type of reprocessing error that has the most attention, the most body of literature behind it, I suppose, if you want to even say that, and also probably considered one of the more higher risk for reprocessing errors. And that's not just because of the type of equipment that you're dealing with and what happens on the individual patient level when you're using the equipment, but also the fact that endoscopies are occurring within hospital settings and outside of hospital settings. And outside of hospital settings, quite often it can be in a smaller clinic where the individuals who are doing this may not be quite so aware of the kinds of practices that should be associated with the reprocessing. So the first case here is something that was published in 2009, and this involved a number of breaches in the reprocessing of endoscopes in 3 Veteran Affairs hospitals through the United States. And basically, the errors came down to 2 sort of areas that were being improperly dealt with. One was a lot of the auxiliary water channels that are used for irrigation had the improper connectors attached to them. And this picture's up here specifically for people to be aware of the fact that this wrong connector looks very, very similar to the one that should be there. But this particular one did not have a one-way valve. So the resulting problem is you could get backflow through the irrigation process of bodily fluids into the instrument. To complicate matters, a number of the organizations involved here were actually not reprocessing the tubing properly either. So the tubing is supposed to be disposed at the end of the day and reprocessed between patients, and that was not happening consistently. And there are a number of other smaller breaches that were identified in this particular paper as well. So lots of problems. They weren't sure how long this was going on, but they basically defined a period of the problem being between 2003 and 2009, and decided in the end to not just disclose, but actually recall over 10,000 patients who may have been affected by this problem. Those patients were tested for bloodborne pathogens, which include HIV, hepatitis B, hepatitis C infection. And lo and behold, they discovered that 8 of the patients had hepatitis B infection, 25 had hepatitis C infection, and 5 had HIV infection. Well, what do you do with that information? How do you know if that was acquired because of this exposure or other risks that may have happened during that long period of time? So, this is the kind of thing that you grapple with when you decide that you want to go ahead with testing, not just a disclosure piece. And it's very concerning, to both patients and to the people running this when you can't really tell how long it's been going on. Now, endoscopy is, like I said, one of the things that's considered higher risk in terms of reprocessing errors and consequences like infections resulting from it. So it's important for us to have a good understanding of how frequently this happens, what the common themes are. And this is actually a great little synthesis of it, a paper that came out in 2012 that attempted to summarize that information. So they did a literature review, a search on your usual medical databases, sources of information, but also the internet, looking for government reports, looking for media reports, and anything else that's related that cited some kind of an endoscope reprocessing error. And they were defining the period between 2005 and 2012, thinking, we're probably going to have so much information to synthesize, we have to actually have a scope that's going to be manageable. Well, what did they find? There was actually really just one peer-reviewed article that reported on reprocessing errors of the endoscope type in that period. The rest of what they found was media reports and some government agency reports in the United States where you actually can get some of those reports. Here in Canada, we generally don't have those kinds of reports. So that was a really interesting finding in itself, was that the sources of information, what you would expect to look for is lots of journal articles on this, lots of learning points from it. You just don't find it there. So this table here, which not very clear, unfortunately, projecting very clearly, but this is summarizing a number of cases that came out of their media hits, the media hits that they found that were related to reprocessing errors. And important point to see is that a lot of these problems spanned quite a number of months or years even in some cases. And because of that, it could end up involving a lot of patients. And very few circumstances actually ended up having the results of their workup. So when they did actually recall patients and offer testing for bloodborne pathogens or for bacterial infections that could be associated with it, they often weren't very transparent about what the outcomes were. And you can understand how that happens and why that happens because of the potential and the fear of litigation. But that's an interesting point because it also doesn't help us understand what the real true risk is of these kinds of exposures. So one of the things that is concerning from this is that we typically say, the risk of an infection, either from a bloodborne pathogen or from a bacterial infection related to improper cleaning or disinfection in these settings are it's so low, it's probably negligible. But can we truly say that with confidence, and can we truly quantify that is the question when we don't get the full story. So that's what's interesting about that aspect of things. These are some of the government reports that came out of their literature review. And what was interesting too was that most of the media reports commented a lot on the patient safety aspect of what was going on and kind of focused on that. But in the one peer-reviewed journal article and these government reports, it was less so focused on the patient safety aspect. And I suppose there's a good reason for that, because there are probably some very specific processes that were teased out in those reports that, for us to understand and to prevent this from happening again would be the focus of it and not so much on the patient impact. And again, that fear of litigation that's associated with revealing too much on the patient outcomes. But it is very interesting to me that there's that differential in terms of the focus of these kinds of reports. So now I'm going to move on to beyond endoscopy related problems. So this is actually a case that was published in 2009, and it involved a number of surgical site infections, both superficial and deep, that were associated with arthroscopic procedures involving the knee and the shoulder in one particular hospital in Texas. So over the course of their period of time, that they defined as the outbreak, they had 7 cases. And what they ended up doing is what we often do in these settings. They looked for what could be behind this because it was involving 2 different sites, 2 different types of surgery, but they were both orthopedic, so there likely was a common link. So they did a case control study, and they didn't really find anything that was a clear predictor, clinically at least, for this kind of an outcome compared to their controls, who were people who had those similar surgeries over that period of time but did not develop infections. I should mention that these were all infections that involved Pseudomonas aeruginosa, and when they did the pulse fields of these organisms, they were identical patterns, so it was one strain that was going around. But as part of their investigation, which included your usual infection control practices, what was happening in the sterilization, disinfection, they did find a number of concerns in their central processing department. It did look quite dusty, and there are a lot of other sort of issues with the overall processes and their documentation of their biologic indicators and chemical indicators and all the other quality sort of sides of things. But this was interesting because when you would examine some of the instruments using just your naked eye, you wouldn't see something that was necessarily a problem. However, when they actually went ahead and did boroscopic, so a sort of endoscopic examination of, in this particular case here, this is the shaver handpiece. The suction channels actually had quite a bit of debris, residual sort of tissue, even other pieces of bristles from the brushes that they were using to clean it. That were retained within the instruments after having gone through for the full reprocessing. So they ended up having to do a number of things, which included they changed up all their instruments and everything, but also their cleaning procedures related to this, and went back to sort of the rigid suction as well. And eventually they were able to abort their outbreak. But it was interesting because we often do our inspections using our eyes because you have time and other kinds of limitations, and in this case it required more than that. So this next one that I want to talk to you a little bit about is some surgical site infections that were linked to some contaminated surgical instruments. This was a number of different organisms that were involved in the infection. They tended to be mostly skin flora organisms, so your staphylococci, bacillus species, etc. But they were true surgical site infections. And this involved two different types of surgery, actually, orthopedic surgery, but also eye surgery. So you don't generally put those two together and think of, there's not a clear clinical link between those two. But you can see from this diagram, which outlines what their outbreak appeared as, that they were quite proximal. The infections were quite proximal to the date of the surgeries. So they were clearly linked to that. And they had a number of cases. It was in total 20 cases. Most of them were orthopedic, 15 of them, and 5 of them were eye surgery infections. They did the usual things. They did the usual audits of practice. They, went through our epi analysis of what was happening. They did some environmental sampling, et cetera. And the one thing that stood out early on was some concerns that the OR staff had been voicing for a bit about the appearance of the surgical instrument packs when they were in the OR. They noted that there was a fair amount of wetness and some discoloration as well of the packs. So that became an obvious place to start with their further workup. And indeed, when they went through the processes of what was happening, the sterilizer was working just fine, but there wasn't a drip shelf that allowed drainage. And so there was a lot more condensation and fluid accumulation within the sterilizer. And they weren't allowing their instruments to dry appropriately before they would actually have them go through further steps. So that was, something that from a process point of view, they weren't really following the practices. They were able to get cultures from the instruments and were able to link them back and find a lot of skin flora as well on some of the instruments. So that was an interesting aspect to the outbreak, and they ended up having to do, again, a number of different interventions that was able to abort the outbreak. So since I just mentioned that some of those were eye infections, let's move on to the eye, because you do actually see a fair number of reprocessing-related problems with eye infections, and I have 2 to highlight here. So this first one over here is a number of infections that were identified, 8 infections in particular, with a type of eye surgery, this phacoemulsification, in which this is probably one of the more serious types of eye infections that you can develop, endophthalmitis, which involves the entire globe, so the entire eye being infected, and in some cases can have very poor outcomes. And in this particular case, it wasn't one organism that was causing the infection. It was a few different types of organisms that were isolated, and then some of the cases actually were unable to culture anything that was causing the problem. So they again went through their usual investigations, and as part of it, they ended up doing some flushing experiments and trying to score just what they found on flushing their instruments. And what they were able to find is that they could isolate, first of all, positive culture results on doing so, but under the microscope, all kinds of things were being seen. So they could see, in the one picture you see there's just a lot of debris that's there, but in the second one you can also see that there are bacterial colonies that were forming as well. And so what was interesting is they were following the manufacturer's recommendations for how to deal with reprocessing these instruments, but it just wasn't quite doing the trick. So they ended up purchasing automated flushing machines and reprocessing their instruments in a different way, and they were able to decrease the burden of counts on their instruments by doing that, and they didn't have any significant increase from their usual baseline of infections after that, so they felt that it had been dealt with. But it is concerning that, following the manufacturer's instructions, they still ended up having these issues. Now, this next one is involving an outbreak of toxic anterior segment syndrome after cataract surgery over a fairly short period of time. And a couple of interesting features about this. So toxic anterior segment syndrome is basically a sterile, so non-infectious inflammation of the eye within 24 hours of your cataract surgery. That's can be caused by a number of different things. There are all kinds of reports out there as to different types of chemicals and other things that can lead to this. In this particular case, it turned out that they did their usual investigation, and looked for risk factors, predictors, any associations between the cases. Nothing was standing out at all. So they went back and they actually made some changes in having reviewed their reprocessing. They found some deficits in how they were dealing with things. They made changes. Things quieted down in terms of the number of infections that they saw. And then they had a recurrence, so they saw a few more, and so they had to shut things down. And that's a key point with a lot of these. When you don't have a grasp on what's going on, you're stopping surgery for that particular type of surgery, which has a huge impact on your patients and your organization. So they stopped again and looked a little bit deeper. And all they could really find was when they did some water testing for their steam generator, they found that actually the feed water as well as the condensate in the steam generator for their sterilizer seemed to have a fairly high level of different water impurities, higher than they would have expected. And they went back and kind of thought a little bit more about this and went through their records, and it turned out that the preventative maintenance, the regular maintenance for the steam generator had actually changed. It had been outsourced a few years before that, and the types of things that they were doing, the flushing frequency, et cetera, actually had decreased somewhat. And they were also getting their water from a common boiler within the hospital, which when they went and took a look at, had quite a bit of residue in it. So they thought maybe this is what did it and what was causing the problem. And in fact, when they looked at their instruments and they tried to sort of take samples from them, they actually saw there was a fair amount of especially sulfate on there. And so they thought, this is kind of novel. Sulfates have never really been associated with it, and that's what this table really goes through, with this kind of inflammation before. So it was interesting in that way. But I also wanted to highlight this because this is applicable to not just this kind of case, but even endoscopy-related problems that sometimes people present after their procedure, and they end up having a syndrome that looks like an infection, and it actually isn't. It's an inflammation that's caused either by a chemical that's inducing it, or something like this, potentially an impurity. And depending on what part of the body that's involved, you actually have a higher risk of that eliciting a response, an immune response that seems a lot like an infection. In the end, a lot of times these are traced back to the same sorts of process problems that can lead to infectious risks in terms of how we deal with the instruments, how we, our reprocessing steps as well. So it's very much the same sort of issues that arise, but it's not always an infection that comes out as the outcome. This also allows us to not always pick up on a problem when it's not deemed as an infection, and it's difficult for us in terms of surveillance as well to pick up on some of these things that are less obvious. I think this is the final type of case that I wanted to bring up, and I'm just kind of racing through the cases, which is great. And this is related to cystoscopy, which I had mentioned earlier is also one of the types that we see some of these problems with. And in this case, there was actually an outbreak, again, associated with an organism of Pseudomonas aeruginosa. These were different types of Pseudomonas, different strains of Pseudomonas in the patients. It wasn't all one strain that was going around. But basically, this is how it came about. So a particular region that had one hospital and a number of outpatient clinics, cystoscopy clinics in the area, they're all serviced by one lab within the hospital. And that lab noticed that there were a number of Pseudomonas aeruginosa infections of the bloodstream and the urine that was higher than what it normally would see. And that's what got people thinking about whether there's a problem. So they went through the usual case control study and looked for predictors of that. And they actually found that the most common sort of risk factor for this was cystoscopy, but cystoscopy specifically in the outpatient clinic of one particular urologist. So I think that's demonstrated. This is just the epi curve that we're dealing with at that short period of time where this all arose, and their analysis in terms of risk factors. So they ended up zoning in on that urologist practice and looking at what was happening there. And they found a number of things that were wrong with the reprocessing. So he was using glutaraldehyde solution, but it was one that had surfactant in it for its disinfection, not what you're ideally supposed to be using. The soak times were not corresponding to what was mentioned in the manufacturers. He was actually, this is an interesting one, I almost laughed when I saw this, but the rinsing was actually happening in a vat or a basin of water that would sit there and get changed every 2 weeks. So it wasn't sterile, or if it started to, in quotation marks, smell. So that was the kind of quality assurance that was happening in terms of that particular step. So a lot of egregious things happening. And, In all fairness, as physicians, we're not trained in this at all. And, a lot of times the pressure is to start your practice and do these things, and you really have no idea what needs to be done, or even the fact that there are best practice guidelines out there for you to follow. And then to further complicate this, there really aren't great guidelines for cystoscopy that people know about, right? There are for endoscopy and such, and we kind of extrapolate that, but, it's not clear exactly how they should be dealing with things. So things were remedied, the outbreak was stopped, but it really kind of makes you wonder about what's happening in some of these clinics that are independent and may not have the right expertise at the table. All right, so that's a series of examples and cases that you come across in the literature. There actually isn't a whole lot published out there, as I mentioned, much like that review on the endoscopy piece. And it's interesting that a lot of what's published is related to outbreaks that occurred as a result of it, but probably, as that endoscopy review showed, the majority of problems would be picked up if you were to do surveillance of some sort and do inspections, right? So we're missing a lot of them. But the risk assessment piece is a really important part, and this is also a really difficult part, and also the disclosure and how much you're going to disclose, what how you should be doing that, how you should be communicating it with patients or to patients. There are a couple of papers to help guide this. Not a lot, just really a couple. And I think we all develop our own systems and styles, but this one by Rotella is actually quite nice in terms of telling you what the steps are, and there's a figure here that goes through the protocol that we should all go through when we discover that there's been a reprocessing problem. Of course, the first thing is you want to confirm that there truly is a problem with the reprocessing that led to the issue, because it seems obvious, but sometimes it turns out it's not just that, or it's something else entirely. Always have to go and do what's safest first, so impound whatever the items are, get them aside, don't use anything that could be questionable, like if you wonder if your sterilizer is working properly, don't just keep going with it. Inform the key people who need to know right up front, and then you can have the time to do your more thorough investigation, evaluation of what's happened. Get your line list together, have your list of patients that you may not need to contact later, assess whether there's potentially a risk there, and depending on what actually had gone wrong. And then you can expand your list of people that you get involved once you have more information, et cetera, et cetera. So it kind of goes down, but once you get to the point of 11, having to consider whether or not to get further authorities, public health involved, et cetera, whether to actually notify the patients themselves, that's where you have to have a pretty comfortable way of assessing the risk of what happened. And in this particular paper, the investigators believe in more of a quantified approach to giving risk, communicating risk. And they give a nice example to demonstrate. The example, you don't have to read the whole thing, the paragraph that's there. You probably can't even read it. It's maybe too small. But this was a scenario that they put forward that involved an obstetrics gynecology practice, a clinic, where it wasn't clear whether or not all the specula had truly been sterilized. So in the fictional scenario where they actually went through the processes that had fallen apart, they found that potentially 4 out of 20 patients may have been exposed to disinfected and not sterilized specula. So that's the scenario you're dealing with. And the way that they would approach it is trying to give calculated risks for bloodborne pathogens having been transmitted in that setting. So HIV, hepatitis C, hepatitis B being the common ones that we look at. And in order to do this, you really have to have a good understanding of what the prevalence is of HIV, for example, or hepatitis C in your area. And they use the US prevalence data that they could find. That's often all you have is what's published and what's available to you. But you recognize that that may not reflect what's actually the true prevalence in that community or in that patient's, in your patient population. So that's a big limitation in terms of using numbers for calculating this. And then, of course, the probability that there may have actually been a failure in that patient's case, and et cetera, all these other things that you would, the efficacy of your sterilizer, your washer, disinfector, whatever it is that you use that may have broken down or not been appropriately functioning. And from that, you can multiply all these probabilities together and come up with your final probability of what the risk would be to that individual patient. Not in that scenario, but to that individual patient. So you can do that depending, like I said, on what data is available to you. But a lot of times we don't have, I question how valid that is for every patient. And sometimes you just don't have that data. For example, the hepatitis C, they just kind of said the risk is somewhere between hepatitis B and HIV in this scenario. So this is another paper that is addressing the same issue of risk assessment that helps to guide your disclosure. And they're taking a broader approach and trying to simplify it in a way and make it more qualitative rather than quantitative. And I have to say that this is more of the approach that I take. I don't exactly follow this. I kind of use my own system of communicating it, but I do favor more of a qualitative risk assessment because I can't say for sure that I can give you a number, and I don't want to mislead people by making it seem less of an issue or more of an issue than I feel comfortable with. So you have to take into account the possibility of the transmission of one of these organisms, the bloodborne pathogens, and also what the actual practice breach was. So they have an algorithm in which, again, you go through the usual processes, identifying what the problem is, et cetera, the additional data generation, et cetera, but you basically categorize it into a category A type breach or a category B type problem that occurred. And category A is the obvious ones where, there's clearly a breach that's of significant risk, and you are going to, in those patients, disclose it to them, and you're also going to offer testing in them. So that's clear cut. Vast majority of what we end up dealing with falls into category B, which is there's been some practice breach, and you may want to consider disclosing it to the patient. Sometimes it's clearer than other times that disclosure is a good idea. And some of that also has to do with how your organization deals with risk. So that's something that you have to talk to your risk management people about as well. And then probably some small subset of those patients will actually require a recall and testing. So there's so much judgment that goes into it, but I think that's the nature of this kind of work. Key things you want to focus on are, was it truly that a reprocessing step was missed, or was something just performed incorrectly, but it probably still, attained the kind of outcome that you would want it to, or it just wasn't documented properly, but, that person absolutely remembers that they did it, so those kinds of things are important. Sometimes you have to actually get the people involved to act out what they did. And of course, again, their biases, because after the fact, everything's 2020, so you might have something acted out in a way that it didn't occur, but it can help you to see where the breaches could have occurred. And of course, review all the documentation. But a lot of it also comes down to really effective communication of what happened. So some key things to keep in mind, because we're not well trained in this area at all. None of us are. It's a tough thing to communicate. Always use non-technical language. That's kind of an obvious thing. But you also have to remember to give that qualitative interpretation of risk. That means contextualizing what happened. So even if you decide you want to give a number, like you have a 1 in 800,000, risk of having acquired something from this breach, you have to put that in terms of something that they can digest as well. So compare it to something else, give it a qualitative kind of, interpretation that would help them understand what that means. You want to actually, in some cases, and this is debatable, I don't always do this, but you may want to incorporate some preliminary information about what your findings of testing other people has found. So, and I think that people probably pull this out when they're in a situation where they can say, we've tested X number of people or X number of instruments and nothing has come out yet. And so that's a bit reassuring to patients to hear that their risk feels like it's lower. I don't know how I feel about that all the time, to be honest, but this is something that you see people advocate for. Like I said, contextualizing things in terms of how often you see this happen in your system, that helps. So if there's published information on the risks overall, then that can be helpful. And of course, guidance on testing. And this is what they're really going to focus on, is what do I need to do next? And, when do I have to come back? It's best if you have it all printed out for them and they don't have to think too much about it. Their appointments are arranged for them for testing if that's indeed what needs to happen. Now, again, I said I was going to talk really quickly about single-use devices, so I have just a couple of slides on the legal implications of reusing them. And I bring this up again because the risks of reusing and reprocessing single-use devices really do come down to the possibility of infection being transmitted because they're not created to be used this way, and of the additional problem that there could be mechanical failure, which is less of our issue, but still an issue. And there is a lot of variation in practice of what's happening out there in Canada. Some places ban it, like the Northwest Territories. Some, for particular types of procedures, would ban it, whereas others don't take as much of a vocal stance on it, although nobody's happy about it. Some provinces say it's fine, but you really need to use a third-party reprocessor to do this, and those third-party reprocessors are generally in the United States, where there actually are guidelines and some regulation of reprocessing of single-use devices. Here in Canada, there's no federal regulation. So Health Canada cannot actually, it's not within their jurisdiction to actually do anything about this. So that's a bit of an issue. Whereas, like I said, in the FDA, there is actually some regulation. So people report adverse events to a system called MAUD, which stands for the Manufacturer and User Facility Device Experience. This is, from what I understand, still voluntary. It's not something that's absolutely mandatory, but it is publicly available information as well. But it really comes down to if there was something that happened, say a patient came forward and said, you know, I learned that my surgery was done using this single-use device that had not been reprocessed, and now I have X, Y, and Z. It's really unclear as to what would happen in terms of the legal implications. There really is no case precedent for this. We don't know how Canadian courts would actually deal with this. There's probably some shared responsibility, the hospital, obviously. Even though using a third-party reprocessor does protect you somewhat, there probably is some legal implication to the hospital. Interesting to me, the physician obviously always gets cited on these lawsuits, but you know, in this case, arguments made that as a physician you have to get proper informed consent from your patients when you're going to do something, and you can say that, you make an argument that if you're using something off indication or off label, they need to know about that. But here's a bit of a problem. Most physicians, or many physicians, don't actually necessarily know when a single-use device is being reprocessed and used. So it's a bit unfair to put that responsibility on them. The device manufacturer, obviously, and the reprocessors do come into play as well. So that's pretty much the bulk of the review of stuff that I wanted to talk about. And now I'm going to just end off with some real-life common challenges. And some of this comes from my own personal experience, but also we're very lucky in our department to have hired a new manager who actually has 18 years of experience in the central processing department, with 5 of those years being management in that department to join us. So we had discussions about this, and here are some of the things that we came up with. So these are challenges that can contribute to reprocessing errors. One of them is instrument design, and we're in a very large acute care, tertiary care, quaternary care facility where there's a lot of research and innovation. I alluded to this earlier, but instrument design has become infinitely complex, and so you can have hidden bioburden. And that other case that I talked about with the arthroscopy equipment, where by just naked eye you couldn't see that there was bioburden there, is another demonstration of that particular problem. The manufacturer's recommendations. We always go back to this. It's like our little tagline, you follow the manufacturer's recommendations. However, sometimes they don't provide you with validation reports on what they recommend, and that is a bit problematic. And sometimes you get advice from the representatives that don't always follow what should be done. So you often want to make sure you get the written recommendations and not just follow what somebody says on the phone to you. And also, they don't always give you the step-by-step guidance on how to follow what they say you should be doing. So there can be subtleties that are lost in just following manufacturers' recommendations. Variability in equipment. So this is something in a place where you have a large CPD. Sometimes for the same procedure, entirely same procedure, you can have many different instrument trays with slight variations in what's in there that's used. And they may have slight subtleties in how they should be reprocessed that are different. And this can cause human error, of course, to come into play. So that's another thing that we mentioned here. And similarly, there can be variation in sterilization parameters that kind of come off of what you normally program into your equipment. And so if somebody goes in there and changes one of the parameters because that's what they need to for this specialized piece of equipment that they go in a load, then the next load comes and somebody didn't pick up on the fact that that's been changed, then the next load might be reprocessed using different parameters. So that's a problem, again, that highlights the risk of human error. Instrument tracking. Wouldn't we all love to know exactly where one instrument went all the time? I mean, this is something that would be ideal for recalls. It would be great in terms of losing your equipment because a lot of things walk. However, it is often very costly to purchase these kinds of systems and to maintain them. So that's something that's a real problem. We all aim to centralize things when we have multi-site facilities to maintain more consistent practices as well. This is in best practices as well. But the problem there is that you end up having to purchase a lot more equipment because of transit time, et cetera. Last couple of things. First one is staff competency. Really, really tough because, like I said, equipment has become so much more complex. So try to keep on top of what's going on, including robotics coming into play, et cetera. That's a real problem. But also CPD, central processing, workers here are not regulated, and unions really are trying to fight that need for having too frequent recertifications. So it becomes difficult to try and find that right balance for training. And like I mentioned, human errors behind so many of these failures. This becomes a critical piece. And finally, documentation. It's like everything else in healthcare. We need to document things better because, especially outside of hospitals, it's really our one way of knowing what's going on. And quite often in those settings, they don't always have written policies and standard operating procedures, which they should have. So to end off, what have we learned from reprocessing errors? We've learned, first of all, that we need more transparency on what's going on so we can learn from them. It's a real problem, and I don't know if this will ever change, but I think that's at the crux of the issue. There's really no great reporting mechanism in place. I think a lot of it's word of mouth when we hear about some of these things, or media reports, which is too bad, because we can do this in a way that's productive for everybody, but it doesn't exist as far as I know. And finally, there's a growing problem with real-life challenges on dealing with our equipment because of the way that medicine's evolving and trying to manage these reprocessing errors as a consequence. So that's all I have to say. And are there any questions?
Hi, thanks for your talk. I guess I just wanted to add something to what you had talked about with regards to physicians not being trained and not knowing. That's a general statement with all of healthcare, in that, I think many professionals and many areas of staff who work within the organization, we form teams, and we're always endeavoring to educate each other. And one of the areas in my health authority that we had actually taken on is because we heard that same thing from physicians. They expect that whatever happens in MDR or SPD, that they're doing it all right all the time, but there's an ownership and a responsibility on everybody to know what they're using and what's been done with it and how it's been reprocessed. So we've often included physicians in quality management meetings to ensure that they're aware of the new piece of equipment and what's required for that reprocessing process. So I think that's something that I would encourage IPAC staff to go back and ensure that you get your surgeons and get involved in those OR quality meetings to ensure that they are aware. I think there was a recent lawsuit in New Brunswick in one of the clinics there, and that was one of the things that the lawyer was saying, well, didn't the physician know how that was being cleaned and disinfected? And he didn't. Yeah. So, I guess the ownership and the partnership is really important there for us.
Absolutely. That's an excellent point. I think that as we have more quality committees and things that are functioning, that's a really key thing for physicians to be involved in.
Great presentation. It's kind of scary when you see even the little that's published in the literature and you think about all the complexities. The question I have for you, and a lot of us struggle with this as we go through, if there's a reprocessing error and we either use the quantitative Rutala approach and 1 in 10 trillion or 1 in 10 billion, or a qualitative approach of category A or B. Could you share with us kind of your experience? Because it always comes down to the risk assessment group deciding whether or not there's enough risk to actually notify the patients or not. And I guess my question is, at what point, like if you look at the quantitative Rutala approach, okay, normally if everything went well, there's a 1 in a trillion risk of getting an infection. If that goes down to 1 in a billion, is that kind of where the decisions are made? Could you share your experiences in how do you make that decision and at what point? Because they always focus on bloodborne pathogens, and those risks are, to begin with, very, very minute. Right. And could you share with us kind of your experience in at what point have you actually decided to notify patients, and in what circumstances do you choose not to, because the risk of angst and worry outweighs any risk of infection they might get?
That's such a good question, and it really is so dependent on the scenario. So in some scenarios, it's the type of procedure that's being done. I find that a lot of times when you start digging in these kinds of scenarios, you uncover that it's not just a reprocessing error, but it's also there are practice issues too. So it becomes a combination of these things. And the kinds of things I take into account are what was the reprocessing problem? Was it a large issue or a number of small things that could accumulate to a point where you feel like you've met some internal threshold, and it really is your own internal threshold for risk that's overcome? Or is it just one thing and a bunch of theoretical things? And I think that's really important because absolutely you don't want to be causing undue anxiety and stress over something that's no higher than your population risk of, from other exposures. So I think it's really dependent on the scenario. The other point that you made about so much emphasis on bloodborne pathogens and not on others, 100%, I was going to actually mention that in one of these other papers and forgot, but that is a key thing. So for example, if you have somebody who was performing cystoscopy and things were not reprocessed properly, and because of this overall lack of awareness and understanding of infection control needs, person was not using the proper sort of technique in doing the procedure. I mean, the risks there are potentially bloodborne pathogens, if there are breaches in the mucosa, et cetera, but also bacterial infections from contamination. And I didn't mention this, but a lot of times Pseudomonas and those kinds of things get involved, which can be challenging to treat at times because of the whole issue of biofilms on these instruments. So your usual bacterial infections, so that's a second thing. Then your more resistant bacterial infections that colonize that part of the body quite often. So things like MRSA, your resistant gram-negatives and ESBLs, et cetera, but also sexually transmitted infections. We don't talk about that as well, but that, the same area. It's all kind of depending on what part of the body's involved. So I kind of put all of that together to give an overall risk as to whether or not recall is required. To be honest, we haven't gotten into, and even in our organization, with a number of us doing consulting outside of the organization too, in our sort of vast experience, there's only been 1 or 2 occasions where we've recalled patients for testing. Disclosure may happen on an individual basis more often than that.
Okay.
All right, thank you.
No more questions? Thank you very much. Excellent presentation. Enjoyed it a lot. Thank you.